Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our weekly live stream on Wednesday. Happy to have everyone here. Happy to be here with you as well. Hope everyone's doing well. I have a few friends and colleagues, family members who actually are currently have COVID or suspected for COVID. Luckily, none of them are actually in the hospital. But they're all pretty symptomatic, and sending out some positivity and well wishes to all of them. That hopefully they recover relatively quickly and get through this, as we're all trying to get through this. As a notification, so I am actually doing another live stream later on this week on Friday, I believe at 11 a.m. I'm going live with Dr. Elizabeth Karakoff, dermatologist with ARIA Dermatology, and we'll be talking about psoriasis and psoriatic arthritis. I'm really excited about that. There's a lot of commonality when it comes to autoimmune issues, inflammation issues, when it comes to rheumatologists and dermatologists. And I think that's an interesting collaboration. I think we'll have a really interesting discussion as well. So today what I want to talk about is imaging. And imaging is an incredibly useful thing when it comes to arthritis and tendonitis and pain, but it always has limitations. And you have to always combine it with what you understand about pathology, and also combine it with what you're seeing on that individual patient, and try to come to a smart decision based on that combination. So this comes up in two ways recently for me, questions that patients had for me. First is with the SI joint, and the second is with shoulder impingement. So the SI joint is essentially on both sides of the pelvis. It's a large joint that doesn't move very much, that sits between the pelvis and the lumbar spine, the lower back. And it's a common area for actually pain. In particular, it can make up up to 20 to 30% of lower back pain. And it's something that I see commonly, in large part because I'm looking for it, and in large part because I look at inflammation issues as well. But it's one of those issues that can frequently cause lower back pain and hip pain. And it's one that imaging does not always help with. So this is tricky because you'll have patients who will say, yep, my pain is in this region, and where they're describing their pain is right over their sacroiliac joint. And yet they'll have imaging that's normal. And that's hard for a lot of times patients to understand, because they'll wonder, well, do I really have pain there when the imaging is normal? So the classic example of that would be someone who has an MRI of their lower back or pelvis, and they've got pain right over that SI joint area, and their imaging looks completely normal. That happens quite frequently, actually. The way imaging can be helpful, if you've had an X-ray that shows wear and tear arthritis, or if you have an MRI that shows inflammation. So in those two cases, osteoarthritis could be caused by, could be in the sacroiliac joint. And if you have inflammation in the SI joint, that would be a condition called ankylosing spondylitis. So those are cases where imaging can be helpful. But the vast majority of people that have hip or lower back pain coming from the SI joint will actually have normal imaging, where their X-ray, their CAT scan, their MRI, and even their ultrasound will be normal, but clinically they'll actually have pain there. So how does that happen? So probably more common than actually frank wear and tear arthritis or inflammation in the SI joint would be someone that has what's called sacroiliac dysfunction, which essentially means that the joint itself is being strained and is causing pain. So that can happen if you've had any kind of injury to that area, let's say a strain to the ligament. And chronically, that sort of instability can then lead to pain in the SI joint. So most commonly where I've seen that is in individuals that have had an injury there. Probably the most common one would actually be women after pregnancy. The SI joint very routinely ends up having to stretch or loosen up in order to accommodate the womb, and leading to chronic laxity in that ligament, set of ligaments, can then lead to more pain long-term as well. The great example I always give is for my own mother, who after giving birth to me and then my brother a couple of years later, had basically chronic back of the hip, back pain going on for decades. And really, I recognized that as when I was finally a physician in practice and realized that she was limping and having hip pain. and then coming to the conclusion that she was having SI pain. And in her case, her imaging shows some very mild wear and tear arthritis, but her pain is almost completely coming from that SI joint area. So how do we come to that decision? And how do you come to that decision in other people? So number one would be, where is that pain? So as a classic example would be pain in the back of the hip or in the buttock area. That can very classically be coming from the SI area. If you have tenderness on exam in that area, or if you have on examination, if as you're moving the hip back and forth, in and out, if there's discomfort in that buttock area, that can frequently be SI joint related pain as well, SI joint dysfunction. And then lastly, to really get down to it, if you actually do a diagnostic injection, meaning injecting some local anesthetic, numbing medication into the SI joint and into the ligaments, and actually getting pain relief from that, that can be another really key way that you say somebody actually has SI joint related pain. What's important is not just the SI joint, but the ligaments as well, because those ligaments lead to instability, which then causes pain as well, SI dysfunction. So that's a great case where imaging kind of fails us, but clinically, exam, knowing the history of SI dysfunction and how people are describing pain, it can be very helpful. The second one is shoulder impingement. So shoulder impingement basically means that the rotator cuff, which supports the shoulder joint, gives it stability, gives it strength, and lets it go through a full range of motion, that the rotator cuff starts getting squeezed down a little bit, and that it can actually lead to pain in the shoulder. That's shoulder impingement. So the classic way that people can say someone has shoulder impingement is on examination, as you're either abducting your shoulder, lifting it up, or you're kind of moving it in or out, that it pinches and it gets stuck a little bit and it causes pain. And that is shoulder impingement. So imaging is hit or miss. If you're just doing a static X-ray, it may show that the alignment of the shoulder is a bit off, where the space between the bones is not where it should be, and that may be why the rotator cuff is getting squeezed a bit. But if you do it as a dynamic exam, where you're actually moving your shoulder through the X-ray as it's being shot, that may be one way to actually show impingement. Normally, that's not how X-rays are done, though. MRI can show a lot of the damage that happens from impingement in terms of rotator cuff, but it won't necessarily show dynamic impingement. Ultrasound, on the other hand, is a really great modality for looking for shoulder impingement, in large part because you can actually look at the shoulder rotator cuff, and then as you're moving your shoulder in and out or up and down, you can actually see as the rotator cuff gets impinged, as the biomechanics are wrong there. It's really more of a biomechanical issue, a functional issue, and less of a structural issue. Long term, as those biomechanics and the function is off, where you have squeezing down or pinching down of the rotator cuff tendons, eventually it'll lead to structural damage in terms of the actual tendons and even of the joints around that as well that are being supported by the rotator cuff. But it's really primarily a functional issue that later on becomes a structural one. In the same way, if you're looking for inflammation in the SI joint, it's frequently more of a functional issue rather than a structural one, or an inflammation issue rather than a structural one. It's a lot of times these kind of subtle things that don't really pop out on imaging that well, that it turns out you can really properly diagnose them with good history, good exam, sometimes imaging, but a lot of times imaging is not that helpful here. But in the eyes and evaluation of someone who's trained for this, you can properly make those diagnoses and then treat them correctly as well. Wonderful. Well, as a reminder, I do this weekly live stream, sometimes Mondays, but definitely Wednesdays. And as a reminder, again, I'm actually going live also this Friday, 11 a.m. Central Standard Time with Dr. Elizabeth Karakoff, dermatology, and we're going to be talking about psoriasis and psoriatic arthritis. And until we connect again, I hope everyone is safe, healthy, and doing well. Have a good day. Bye-bye.